Good afternoon, everyone. Welcome to Medicare for All, a conversation with Dr. Abdul El-Sayed. I am Veronica Lewin, Director of Communications at the FXB Center for Health and Human Rights at Harvard University. Thank you all for joining us today. One housekeeping item before we get started. If time allows, our speakers will take audience questions at the end of this event. Please leave your questions in the Q&A box, then we'll do our best to get to them. We have a great discussion lined up. Without further ado, I will introduce our moderator, Dr. Natalia Linos. Dr. Linos is a research scientist and the executive director of the FXB Center for Health and Human Rights at Harvard, where she has helped build a new research area for the center focused on structural racism and health. In 2020, and in response to the COVID-19 pandemic, Natalia ran for Congress to represent Massachusetts' 4th Congressional District. She is currently a town meeting member in Brookline and serves on the board of the Environmental League of Massachusetts. Prior to her role at Harvard, Natalia worked at the United Nations and the New York City Department of Health and Mental Hygiene. She is currently a member of Brookline's Advisory Council on Public Health. Dr. Linos, over to you.
Thank you so much, Veronica, and welcome everyone to our event today. It is with great pleasure that I will introduce our two conversationalists. I don't know what to call them. Dr. Abdul El-Sayed, welcome. Dr. El-Sayed is a physician, epidemiologist, educator, author, speaker, and podcast host. He was the youngest health official in a major US city when he was appointed the health director in the city of Detroit, and he was charged to rebuild the city's health department after it was privatized during municipal bankruptcy. Dr. El-Sayed is a visiting scholar at the FXB Center and also is a scholar in residence at Wayne State University and the American University, where he teaches at the intersection between public health, public policy, and politics. Today, we will be speaking about one of his 3 books, Medicare for All, A Citizen's Guide, which he co-authored with Dr. Micah Johnson. This book offers a no-nonsense guide to the policy. I could go on and on with this introduction, but I will, for the sake of time, move to Dr. Bassett, who probably needs no introduction to this group. Dr. Bassett is currently the director of the FXB Center for Health and Human Rights at Harvard. She's the FXB Professor of the Practice in Health and Human Rights at the T.H. Chan School of Public Health. And prior to joining the center, she served as New York City's Health Commissioner from 2014 to 2018. She's also a physician with more than 30 years of experience in public health, and she's dedicated her career to advancing health equity, both in the United States and in Zimbabwe, where she lived for 20 years. Dr. Bassett has many awards. I will mention just a few: the prestigious Frank A. Calderon Prize in Public Health, a Kenneth A. Ford Lifetime Achievement Award from Columbia, and she was recently elected to the National Academy of Medicine. I say all these accolades because today we will be in conversation quite casually, and with your permission, Abdul and Mary, I will call you by your first names. No disrespect, but I find that that helps the conversation flow more naturally. So Abdul, over to you. Let's jump right into the book. What inspired you to write it, and maybe even give us our top, your top 2 to 3 messages that you hope the audience can go home with today and say, oh, this is what the book is about.
Absolutely. First, it is a privilege and honor to be with you all. Natalia, thank you for your leadership. And of course, Mary, thank you for yours. Really grateful to have the opportunity to spend some time together at the FXB Center from my home in Ann Arbor, but also hopefully in the future, some more time in shared space. And really excited about the work focused on the intersection between human rights and health. And I came to healthcare policy from the space of public health policy and politics. I was, as you mentioned, Natalia, I'm a social epidemiologist by training and a former health commissioner. And I'm a physician also by training, but my passion was always about understanding the places where people live and learn and work and pray and play beyond the clinic, where, the 0.1% of the time where they're actually in front of a physician. And it became very clear to me, both in my epidemiology training and in my medical training, that understanding why people get sick, particularly understanding why some people are more likely to get sick than others, has a lot more to do with understanding the places they live than it does with what we can do in a clinic for them. That being said, healthcare is 19% of our economy. Nearly $1 in $5 that is spent in our entire economy is spent on healthcare. it has sequestered so much of the financial resources in health, and therefore so much of the conversation about what we can do to improve health. And I ran up against that when I was a health director and saw firsthand in a city like Detroit the way that we were unwilling to invest in public health, even as health care remained something that that we were having a conversation about. And the consequence of that is that we fail both to build out the kind of communities that can keep people healthy in the first place, and then also to open up access to clinics and hospitals that can give people health after they've gotten sick. And the other part of this is that I ran for office. And of course, healthcare is a major conversation in the political space, because in our country, we have so fundamentally failed to solve it. And when I ran on a platform of Medicare for all at the state level, so state level single payer healthcare. And the goal we had was to be able to connect people across this conversation. And I realized that ultimately politics is just a really terrible place to have a conversation about health policy, which is a sad recognition, but it's also a very true recognition. And what I realized is when the campaign ended and I didn't win, that we needed to be able to have a conversation that connects the brokenness that people understand in the macro healthcare system to the brokenness that they experience every day in the micro system that they have to deal with. And the problem with that is that there just hasn't really been the effort to do that. And that's what we want to do with this book. So I teamed up with my good friend and colleague, Micah Johnson, who was critical in helping to put together my state level single payer program. And we worked together to write this book, to try and pull the conversation back out of the political arena and put it in or at the kitchen table where people are having conversations about their own healthcare, to understand how the broader brokenness and incentives in the system shape the experiences that people have every day in healthcare. If the message that we want folks to understand more than anything else is, number one, that the system that we have today exists because of a number of misaligned incentives that ultimately funnel down to really powerful and very rich people wanting to become more powerful and more rich. Their capacity to reach across the financial firewall that ought to exist between our economics and our politics, to shape our politics in that respect. And that a single payer government national health insurance program doesn't just solve the coverage problem, but solves all of the other problems underneath the coverage problem. The fact that even if you have coverage, it's tiered, that tiered system tends to map onto systemic racism in a pretty profound way, that the incentives in the system leave hospitals and insurance companies consolidating collectively, playing off of one another's incentives to continue to sequester more money. That the ability to free our healthcare dollar from the grips of the healthcare system and put it into the public health system happens when you have the same payer for public health that you do for healthcare. That all of these things are only achievable if we are willing to stand up and organize around them, that this really is a political question in the end, because it has to do with how we allocate scarce resources, healthcare being one of them. And so all of that is to say that I am an accidental health policy nerd, a healthcare policy nerd, and the hope for this book is that it starts to make the argument for a more just, equitable, sustainable healthcare system. And before we move on, I just want to read just a little bit from the book, because I think it does set the standard here in terms of what we were trying to get across. So this is from the introduction, and in so many ways, what we wanted to do was respond to folks who say, well, government healthcare is something that they do in other countries, but it is frankly and fundamentally un-American to do something like that. And so let me just read to you a little bit about both where we are in our healthcare system, but also the first time our government took its responsibility to actually answer the call that is framed in our Constitution to promote the general welfare in the preamble of the Constitution. First time they took it seriously and actually decided to take it on directly. And that was as early as 1798. In 1798, the Fifth Congress passed, and President John Adams signed an early attempt by the fledgling republic to promote the general welfare, an act for the relief of sick and disabled seamen. At that time, international trade was vital to the well-being of the United States, although being a sailor was a particularly dangerous trade. To protect its merchant marine, Congress passed a law creating a system of government-run hospitals for seamen, funded by a mandatory tax on their earnings. As science advanced through the 19th and 20th century, American government acted as a catalyst to convert new knowledge into broad improvements in general welfare, improving sanitation, putting fluoride in drinking water, ensuring widespread vaccination, funding new hospital construction, and guaranteeing health insurance for senior citizens. Excuse me. Modern healthcare has developed tools that humanity couldn't have imagined in 1787, from vaccines and antibiotics to robotic surgery and targeted immunotherapy. Because of these advances and so many others, nearly 250 years after the people of the United States ordained and established the Constitution, American life expectancy has more than doubled. And yet, perhaps by the standard of our time and the power and wealth of our country, we are yet failing to promote the general welfare. Life expectancy in the United States is nearly 6 years shorter than in Japan, the longest lived country in the world. American infant mortality ranks 55th in the world, and American health disparities by race and socioeconomic status are among the world's steepest. Perhaps worse, life expectancy has stagnated, even falling for 3 straight years between 2015 and 2017. Rather than the infectious diseases of the past, the diseases with a predilection for the young today are diseases of despair, drug overdose, alcohol misuse, and death by suicide. For the population at large, cancer and heart disease are the top killers. For this mediocrity, Americans pay, by far, the steepest prices for healthcare in the world. We spend 18% of all of the money in our economy on healthcare. We are projected to spend $12,000 per person on healthcare this year in 2021, doubling the average in comparable countries, and our costs are increasing rapidly. Those increases have fallen hardest on poor, working, and middle-income Americans. 1 in 10 Americans have no healthcare coverage at all. Those who do are seeing their annual insurance premiums explode, even as the insurance comes with the rising deductibles and out-of-pocket costs that leave families financially and medically insecure. Indeed, more than 2 in 5 Americans who receive a cancer diagnosis depleted their life savings within 2 years. So that is some context for where we are and the precedent that was set in investing in healthcare directly on the government dollar. And so I look forward to this conversation, and I just want to leave you just with a quick final note in this opening introduction, which is that oftentimes in spaces like this, we have abstract conversations about ideas that map to real world experiences that real people experience. And because of the privilege of being able to engage in this space, the very fact that we are connected by wiring and tubing that gets us real-time pictures of each other, or that our workplaces allow us to do this kind of thing. Oftentimes we're privileged so that the abstract discussions that we have about issues that matter in real ways to real people don't actually affect us. They may have in the past, but they don't actually affect us. And I think it's that conceit that allows us to treat abstract ideas as abstract, and that leaves us from being willing to pick up the work of getting political. And I know politics is it is a problematic and dirty word in the academy, but it is the way that decisions get made about how we allocate resources. And we are only going halfway if our conversations about these issues stay abstract and they don't animate a certain need and responsibility to get involved in the public debate and discussion. And so I do hope that we don't shy away from the discussion of politics either today or broader, what we do coming out of a conversation like this one. Because if you get hot, steamy mad about something, it doesn't change something until that steam gets turned into real work, right? And so rather than just steaming, we have to turn it into a steam engine, and that is deciding to get involved in this work. And so I really look forward to the conversation, and I hope that it inspires some of us to move beyond the abstract into the real world work of trying to create the kinds of outcomes that people deserve in this country. So.
Thank you so much, Abdul. And I was remiss in not mentioning your run for governor in Michigan in the introduction, because it actually inspired me to run for office, seeing a social epidemiologist step in. And I hope that many people in the participants today will also step out and say, this skill set of being a physician and an epidemiologist, and you can put that to good use to bring about reform. And because I agree with you, the whole question around Medicare for all is so much a political question. But Mary, over to you. I mean, you have been in public health and also worked as a clinician for decades. And so my question is, while reading Abdul's book, were there any aha moments, anything that was surprising in the data or the analysis, anything that you want to share?
Sure. I have to say first, just how pleased I am to be in conversation with both of you, who really through your work have modeled what it means to be a scholar activist. And I absolutely endorse, although politics aren't for me, the idea that we have to get political if we want to help change the world. And so I'm really pleased to be in this conversation. I've been a supporter of single payer health insurance in the United States for a very long time. As a House officer, I wore a badge on my white jacket that said, healthcare is a human right. And I also want to underline that it's fully within the right to health that we talk about, Medicare for all. And it also is a public health issue, not only because people have to have access to healthcare if they're sick, but because the way our system is set up is such a drain on our economy that it has these knock-on effects that have left our unions, if they exist, fighting for health care coverage instead of better wages and so on. So I have been convinced of the argument for a long time, and the book, Medicare for All, really coheses these arguments. But what I learned from it that I hadn't really fully understood before has to do with the kind of the two key actors in our current situation. There's the insurance companies and the healthcare providers. And I'd always really thought of the bad guys as the insurance companies. They're reaping huge profits. We're now with these plans that are funneled through private insurers with public dollars, the Medicare Advantage plans, which are still growing and represent something like 1 in 3 Medicare covered individuals. These, not only are they profiting from the paychecks of individuals, but also from government coffers and all kinds of subsidies. So I didn't realize that the healthcare sector has been more or less a partner in this. And one thing that you make clear in the book, Abdul, is as the amount of money, I mean, when I was an undergraduate and a medical student, it was 10, 12, 11, 12% of our economy. Now, as you point out, it's up to nearly 20%, and we don't know when it will stop. So the pie has gotten bigger and bigger. And even if the healthcare, this is my understanding from your book, even if the healthcare delivery system is getting a smaller slice of that pie, the amount of money in that pie, to use George Bush the Younger, the pie is so high that it's in the interest. It's also in the interest of the healthcare sector. So doctors and hospitals who you would think would be standing up against this corporatization of healthcare are in fact partners in it. Anyway, that's my take. Do you want to comment on that, Abdul?
Yeah, I'd love to. And I think the point you're making is a really important one. It's also that point that the underlying size of the pie has fundamentally actually changed the nature of the institutions that provide healthcare in America. In the past, you go to the 60s, 70s, you had a mix of public and nonprofit hospitals. Today, you end up having a mix of highly incentivized nonprofit hospitals and for-profit hospitals. And what they're responding to is the fact that there's a lot of money to be made in a system for which the underlying goal of actually providing healthcare has been abstracted away and replaced by the overriding goal of making money. And so you're having hospitals get bought up by for-profit hospital chains, and then also smaller hospitals getting bought up by private equity firms. There was just a story this weekend about Philadelphia's Hahnemann Hospital, which was one of the most important local hospitals in Philadelphia, and again got bought up by a private equity firm and then shut down a year and a half later. You have a situation where the DMC, one of the largest hospitals in Detroit, the Detroit Medical Center, was a public hospital. It then became a nonprofit hospital and was sold to a publicly traded private corporation that now can't figure out how to autoclave its surgical instruments because they're trying to chip away at their overhead costs in any way they can, which of course means that the service provided in those local communities, who disproportionately, the patients for which tend to disproportionately be low-income Black Americans, tends to be cut in the process. You look at the 20 hospitals that closed in 2020, they were all or majorly owned by hospital chains who found it not profitable to continue to run them, so they shut them down. And so you have this extreme circumstance where the consolidation of hospitals to try and capture more and more of that underlying profit tends to lead to, ironically, the shutting down of hospitals in disproportionately Medicaid eligible communities or uninsured communities, which gets back to the insurance system, right? And so it is this system, right, that is operating, both sides of which are operating for profit, neither side of which really quite cares about the patients underneath the system from whom who they're exploiting for or extracting from for dollars. That tends to operate in these ways that seem to make sense from a business perspective, only if you've forgotten that the purpose of the healthcare system itself is to try and provide healthcare for people. The last point I'll make is in the past, it's been interesting, right? Physicians used to be the central provider node of opposition to universal health coverage, right? The AMA destroyed any effort at national health or even state health insurance in California. Then they did destroy the Truman effort for national health insurance. They invented the term socialized medicine, have been on the wrong side of this debate from the get-go. But what's been interesting is that there's been this trade-off between physicians and healthcare corporations, right? The hospitals. And as hospitals have gotten more and more power, what's happened is that they started to extract from physicians, and now more and more physicians are starting to see the light on the importance of universal health coverage as they're being extracted from more and more patients in less and less time, more and more paperwork, and less money, and all of this because of the power of hospitals. And so you've seen the power of the AMA dwindle, while the power of the American Hospital Corporation or Hospital Association has grown, and the preferences of American doctors are starting to change. The median doctor in 2018 no longer worked for another doctor, a private practice. They worked for a major corporation, a large healthcare system. And that year, the median doctor no longer opposed Medicare for all. They supported Medicare for all. Those two things are not coincidental. And so we're seeing the shift in preferences on the provider side. The whole time, though, right, we're seeing pretty consistent leveraging of the incentives that exist on the part of insurers to continue to promote the major corporatization of American healthcare.
So I'm going to take this to the patient perspective. And I want to ask you a little bit about what are the most common gaps in healthcare coverage. And Mary, to you also, how is institutional racism embedded? Already Abdul alluded to, which hospitals have closed down, and how can we think about it from a patient perspective? Why is this conversation so relevant? I don't know, Abdul, do you want to jump in first with the broader question, and then Mary on the inequities?
Sure. What's happening today is that first 10% of Americans are locked out of the system. They don't have health coverage. The lowest income Americans, depending upon where they live, may or may not have access to Medicaid, depending upon if their state expanded Medicaid. And for upper middle and upper income Americans, their experience also is far less secure than it used to be. Why? Because insurers realized that they could piggyback off of the justification of the idea that cost sharing reduces medical expenditures overall, to leverage cost sharing to, in effect, offer two different price tags, one to the consumer and one to the employers who are responsible for providing health insurance in our country. And so if you've signed up for health insurance, you know that there is a premium, and then there's a deductible and a copay. And in order to understand that, right, you kind of have to go back to the advent, which was really the 80s and 90s, where you started to have this quote unquote cost sharing. But the idea here, right, isn't that we need to reduce the wasteful use of healthcare, because even in the canonical Rand experiment, the finding was that yes, people use less healthcare when there's cost sharing, but they're not very good at segregating whether or not it's useful or useless, right? And so you just end up with people just saying, I'm not going to get healthcare at all, which of course makes sense because there's a reason you go to the doctor. It's not just to get your treatment, it's to get your diagnosis. So if you don't know whether or not the healthcare that you are going to consume is actually important to consume, you just don't consume any of it. And this is what cost sharing has left. But it's been exploited by the insurance industry, in effect, to pass on a lot of the bumper cost, the sticker cost of healthcare onto people on the back end. And so what that means is that you've got the median American who's paying a premium that is upwards of 5 to 10% of their take-home pay. But then, the median American's deductible, which is, of course, the paywall that you have to get the insurance that you already paid for in the premium, right, is $3,600, which for the median family is making $69,000 a year, is a single biweekly paycheck. I don't know many families of four earning $69,000 a year who could just go without a paycheck simply because somebody got sick, right? And that's what it's meant. On the racial inequities point, I just want folks to understand just how starkly this plays out in the system. The fact that we have a tiered healthcare system itself means that on average, a Black body is valued at 29% the value of a white body. Where do I get that math? Let's just take kids, because all kids are covered per the law. 57% of Black kids are covered on Medicaid. 32% of white kids are covered on Medicaid, okay? Medicaid reimburses at about half the value of private insurance, okay? If you take that math, right, and you multiply it across the proportion of people who are Black on Medicaid versus white on Medicaid, you end up getting this number of about 28% the value. So thinking about this, right, just the value of a Black body, caring for a Black body, is 28% the value of caring for a white body. Now, we're at a school of public health here. We recognize that medicine is not the be all and end all of health. But when the system that already sequesters 20% of all of our healthcare dollars, right? Excuse me, all of our dollars in general, right? But almost all of our health dollars. If that system values a Black body at 28% or 29% the value of a white body, right? What that means is that the money that could have gone into solving systematic inequities, whether it is thinking about air quality and asthma, whether it's thinking about lead poisoning and lead abatement, whether it's thinking about the quality of drinking water, whether it's thinking about the quality of schools, that money is sucked into the system that systematically undervalues Black bodies. And if we've assented to a healthcare system that is dominated by profit, right, what we're basically saying is that it is okay, right, that you can focus on quote unquote paying customers when it comes to something as fundamental and foundational as whether or not their bodies get healthcare if they get sick. And so it bakes in systemic racism and instantiates in the system. We don't talk about it that way, right? But that is the de facto end outcome. It's the same way that, funding public schools on property taxes isn't inherently or purposively racist, but because it maps along and brings along, right, systematic racism in the form of investment in property taxes, et cetera, right, it is a racist policy, and the outcomes of the policy are certainly racist. And so we should start talking about it that way.
Thanks, Abdul. And Mary, over to you. I hadn't thought about it with those numbers.
I had a dog. I know I had a dog barking in the background. If the dog comes to agree with me again, I apologize in advance. But I think there are two parts of at least two parts, maybe three. One is the type of care that you, Abdul, have been talking about that's delivered to people of color. Blacks, Latinx, Indigenous people. We haven't talked about all of the problems in the Indian Health Service. So there's the problem of the quality of the care, the simple availability of care, and a lot is talked about as a problem with the healthcare providers. And we all have heard increasing conversation about the problem of racial bias that providers may not even be aware of. It's that kind of bias that makes the identification of pain and the treatment of pain in Black patients, not appropriate. The idea is that Blacks can withstand more pain, a very old idea, and that Blacks may be seeking pain relief for reasons other than actual pain. A notion that extends even to children, so that Black children are less likely to be adequately treated for pain. So there's that kind of bias. But then there's what you've been talking about, Abdul, is that the whole system that delivers care to communities of color is underfunded. And the result is that you have hospitals that simply don't have the equipment or the capital investment to deliver what we consider standard of care. They don't have cardiac cath labs. And all of that is literally structural. the hospitals simply are not as well equipped. The doctors don't have access to the type of care. And then there's the issue of, what all of us face, frankly, with our health insurance plans, that we have literally no idea what a hospital visit is actually going to cost us. We don't know when we don't know. Most of us expect that it will end up costing us more. And, the whole copay, deductibles, everybody's mystified by that. I'm mystified by that. And the result is that people, in anticipation of hidden costs, fail to seek care. So despite having such an expensive system, we have lower utilization rates than in other wealthy countries, because people aren't looking, are afraid of the cost. And that tracks along racial lines. So that's part of it, that we have a system that contains prevention as well as curative care, that is not delivering high quality care to groups that have been discriminated against on the basis of income and racial classification. And then we have, I'm sure for people listening to us, they wonder, this is so horrible that we're talking about. Why aren't we fixing it? And I think that racism comes in on that as well. That part of the reason that there's so much resistance to government-funded national health insurance, single payer health insurance, is because of the belief that it will be a benefit that is not equally delivered, that people who don't deserve any more government funding because they've gotten too much already will receive this benefit, and that it won't go to the hardworking code word for white Americans who deserve it. So this is, in my mind, one of the racism represents a real barrier to tackling what we all need, which is confidence that if we should get sick, that we have health insurance, that it will be adequate. And the fact that we live in a country where millions of people don't have health insurance at all, in a country as wealthy as this, should make all of us feel ashamed. So why don't we fix it? I think the problem is also racism.
Thanks so much, Mary. And on the why don't we fix it, Abdul, what are some of the alternatives that people, either in political circles or even debates in, schools of public health, what are some of them for an audience that is more of a lay audience and who says, of course, this makes sense, but what are the ones that are being discussed? And in your view, are any of them steps in the right direction, or do we really need to go straight to Medicare for all?
Yeah, most of we'll just say good faith arguments, right? Arguments that say that the market can solve all these problems, I just don't think are good faith arguments that are supported by any real evidence. So let's just say good faith arguments. They include, right, working on the platform of the ACA to offer something like a public option that can be either narrow or wide. A narrow public option being, your ability to buy a public health insurance program on the ACA exchanges, for example. A wide one being, employers could buy into a public option if they wanted to. There are other approaches which say, well, can we work from where we are right now into a sort of Medicare for all world in a slow process by perhaps including everyone who is not covered right now on a public option de facto, and then keeping them on as folks age, and then getting children, for example, onto it over time, and anyone who's on it stays on it, so that over time it starts to grow. And then there's Medicare for all, which is to say we go from where we are right now and we transition within a set number of years into a national health insurance program. So to step back, I just want to put a quick definition on what Medicare for all is and what it's not. Medicare for all is, it's actually not Medicare. Medicare is just a way of talking about a single payer healthcare program. So oftentimes when you say Medicare for all, people say, well, there are so many holes in Medicare, right? And that is true. But the idea is that you have a national health insurance program that then applies to everyone, that there is no such thing as a necessary component for private health insurance, and that it offers all of the basic services. Now, we also believe that a Medicare for All program would have to require a coverage for basic healthcare needs, which I would say it would include anything that either today or in the future could threaten your life and your well-being. Would include everything from dental to vision to auditory coverage, mental health, of course. And the question is, does it include copays? A strict definition would say no, but all of the proposals that are being considered right now would cover any sort of cost sharing. So there'd be no deductible and there'd be no co-insurance costs. So a public option as it stands right now says, all right, you can buy access to this government insurance, but it doesn't necessarily cover you, right, if you can't afford it, which is sort of the problem with when people say a public option is going to get us to universal coverage. The other heuristic problem here is that universal coverage is not the only problem. If we gave everybody universal coverage that itself was broken coverage or too expensive and unaffordable, it wouldn't really actually solve our problem. And so it's not just coverage, it's also dealing with the consolidation challenge. It's also dealing with the increasing cost challenge. It's also dealing with the problematic power issues inside the system. It's also dealing with the inadequate coverage for public health. And the reason that Medicare for All, I believe, is the best solution is because it is a solution to all of these programs in one policy, right? Rather than piecemeal trying to solve all of these programs separately. And a lot of times folks who believe in sort of an ACA-based approach will say, we can solve this problem with this policy, we can solve that problem with this policy, we can do it this problem with that policy. And the challenge with that is that, well, you end up having this extremely high technocratic fix that is very, very difficult to actually explain to people and maintains a labyrinthine system that a lot of folks can't engage with and sustains the kind of inequity baked inside the system that gives better coverage to richer people, that sustains the inequity challenges that we've talked about. I had the privilege of serving on the Biden-Sanders Unity Task Force. Our job was to write what ultimately was Joe Biden's healthcare platform. He does not support Medicare for All. I was one of the Bernie Sanders appointees. I do support Medicare for All. We were 8 people, 3 of us were Sanders appointees, 5 of us were Biden appointees. And the framework that we brought to it, right, as Medicare for All supporters, was that the way to think about how to make ACA coverage better is, at least in my mind, is to hold it up to a very clear rubric. A, does it extend more healthcare to more people? B, does it reduce the power of corporations? And C, does it reduce the individual costs by picking up more of those costs by government, right? Does it expand government engagement? Does it reduce corporate power? And does it extend more healthcare? And the public option that Joe Biden ultimately ran on was a far broader shouldered public option than the one that he had initially run on in the primary. And part of that was because the primary was contested mainly in late 2019 and before March of 2020, and the general was contested after June, and there was a big change there, which was the pandemic. And so his public option met those 3 criterion that I just explained. And so yes, it is a step in the right direction. You'll get folks who are purists, and I think you can only really be a purist if you think that the problem only exists in abstract, that there aren't real people that you're talking about. And so, yes, I believe in Medicare for All. I believe that that's the way that we ought to pursue things. I literally co-wrote a book about that. But if it can extend healthcare today, if it can reduce the power of corporations, I think it is a step in the right direction. So that's what we proposed. If Joe Biden were to say tomorrow, you know what, I've seen the light on this, and I believe in Medicare for All, I do believe it would be better than what he ran on. That being said, I highly doubt that's going to happen. He's been around for quite a while, and he hasn't quite seen the light yet. So there's that.
Mary, do you want to jump in either on that piece, or if you think, you've been a proponent of single payer for many decades, like if you want to reflect at all about where we are today versus, where you've been in different stages of your career?
So I agree with Abdul's argument, which is basically that we don't want to make the perfect the enemy of the good. when the Affordable Care Act was implemented, the number of uninsured adults in New York City, which had a lot of the success of the Affordable Care Act and extending coverage was because of the expansion of Medicaid, the program that is for low-income Americans, not because of this complex marketplace, which only insures a small section of the population. But New York, the proportion of adults who were uninsured went down substantially. And really, a principal barrier were undocumented people in New York City and in the country who weren't eligible to purchase health insurance on the market. So many more people were covered, but we still had 10% of adults who weren't insured. Children, as you pointed out, were effectively fully covered, and that's a lot of people. But I can't say that it's not progress. I used to use the example of my daughter who had aged out and was not working. And so I went to buy her coverage. And what I got for her was a plan that was a catastrophic plan. And I figured out that between paying for the plan, which was about $300 a month, and paying for the deductible, if she actually needed care, if she were in a car accident or had leukemia diagnosed, that she'd have to pay the first $10,000 of her care between the plan and the before her coverage kicked in. And that's a lot of money. So it wasn't that great. But it protected her against, whatever. I mean, the costs when people have serious health problems are not $10,000, they're far, far more. So it was absolutely better than nothing, but it didn't get us to where we needed to be. And so that's what I keep saying, that we haven't, that things are better. And I hope that the incentives to expand Medicaid there were 12 states, I think, that didn't accept it. And it still seems like it's contested. One state, you'll know it, Abdul, they did a citizens vote on expanding Medicaid that was then overturned, or an effort in place to overturn it by the legislature. So I hope that we expand Medicaid and that we get more people covered. But even if you have health insurance, it's often not a protection against disaster. We have to do better in a country that could offer people such great care. So do you want to comment? I can't remember that story about.
I believe it's Missouri.
Missouri, yeah. Yeah, I think you're right.
Yeah.
So, I mean, these are pure, like the state of Texas, just pure sort of mean-spirited behavior. They won't, they have the skinniest Medicaid plan around, and they won't expand it, even though it's not Texas money. It's federal money out of some kind of, I don't know, it's ideological. That they just don't want to see the expansion of public health insurance.
Yep.
Yeah.
Mary, to your earlier point, you think about in the South, who lower income folks tend to be because of massive structural racism. They tend to be Black folks.
Yeah.
And so this narrative of deservingness is what animates so much of that mean-spiritedness around rejecting federal dollars to provide people health care. We are a day past the 100-year anniversary of the Tulsa race massacre. Mm-hmm. And you think about the subtext of what was operating there. It was about a group of Black Americans who, despite all odds, only 44 years after Reconstruction, had built a thriving community for themselves that had built power. And white folks in the city just weren't having it. And they used the thinnest pretext to fundamentally destroy Tulsa. And it was, a lot of folks think about, this massacre as being a mob violent action. But actually, many of the people who participated were deputized by the Tulsa Police Department to wreak this kind of havoc on this town, this part of the city called Greenwood. The Oklahoma National Guard estimated that they arrested and interned 4,000 Tulsa residents, Black residents, to keep them from being able to defend their part of the community. And it is the same sense of unbridled, structural, institutionalized racism that says that we are going to leverage health insurance inaccess, right, to quote unquote put you in your place. And we have to identify how this works now. And just because it's perpetrated by an authority of government doesn't make it right, doesn't make it fair, and doesn't take away its racism, right? It is the same set of actions that we saw from 1921 perpetrated today in 2021, and it has disproportionate impact on Black folks.
Right. The majority of the states that have declined Medicaid expansion are southern states, just as you say, the vast majority, nearly all of them. So, I think that the answer is that people say this doesn't make sense, that we can afford, we're already paying for a system that should be able to provide health care for everyone, and we're not getting it. And the reason is because too much profit is being pulled out of the system that's not being delivered in patient care. And that's not, imagine if we ran even the police department like that, or the fire department. These are services that we can't look after for ourselves. We have to depend on systems that reflect the collective action to give them to us. We need to have a system that is universal, and that leaves nobody out, everybody in. That's one of the slogans, I think.
PNHP, yeah,
So,
Physicians for a National
yes.
Health Program.
Yeah, of which I've been a member, in full disclosure, for very many years. But I mean, in my city, in New York, what we did in the health department when I was there as commissioner was try and make sure that people claim all their benefits, that when they have, are eligible for Medicaid, that they get covered, that they understand what their benefits are, and that we, promoted the exchange and tried to make it simpler for people to get covered through the exchanges, which were subsidized. I don't know if people understand how the Affordable Care Act works, but it did represent a large shift of funds to people who are low income. Some people say that it was the largest subsidy since Social Security. But still, we haven't solved the problem. And that's why everybody should read your book, because it explains that that we can solve this problem, and that the kind of definitive way to solve it, in my view, is by having a government-run single-payer system. Now, who opposes that? It used to be doctors, but doctors have shifted. The public has shifted. So we're left with the industries, the corporations, who have a huge power in the halls of our elected officials.
We do have a few questions in the chat, and I do want to encourage
Okay.
others to jump in too. But no, I mean, it is to that point. So and two of the questions, I'm going to summarize them together. One from Susan Lloyd McGarry and one from Kathleen Hamill are, I'm convinced, but besides voting, what can we do? And how do you envision mobilizing change and action? And, what, now that your book is out, what are the strategies that people, whether at FXB or advocates, can concretely do, Abdul?
I think sometimes we think about our system as being binary. It's, you either are voting or not, or you are, running for office. And I think there's, Natalia, as you all know, there's so much in the middle there that happens. And And that, I think, is the work of organizing. And what I mean by that is that we have a whole chapter in the book called Organizing versus Advertising, because in the end, that's what this fight's going to come down to. And they spend not just millions, billions of dollars a year lobbying lobbying our elected officials and trying to, in effect, systematically disinform the public about what reform would mean. And just to give you a sense of that, what I mean by this, if you look at industries buying lobbying expenditure over the past 20 years, number one is the pharmaceutical industry, number two is the insurance industry, number eight is the hospital industry. And the numbers here are eye-popping. The pharmaceutical industry spent 4.4 billion with a B dollars over the past 20 years. Insurance spent 2.7 billion with a B. And to put that in perspective, in 2020 alone, health insurance spent $150 million across 845 lobbyists. So that's 1.95 lobbyists per member of Congress. Imagine having two people who are paid full time to lobby you just from one industry. Like, that's what that looks like. And then they built in 2019, there was this Partnership for America's Healthcare Future, which was a coalition of all of these lobbying groups that spent millions of dollars running ads. You probably saw them about Medicare for All. Here's the funny thing. The minute that Joe Biden was nominated, they just switched out the words. So instead of running the ad against Medicare for All, it was against the public option. And what that tells you is that they are trying actively to oppose any sort of change. And the way that we win is by doing two things. Number one, it's by building a movement of people who are going to push politicians to do the right thing. We have to be our own lobbyists. I hate to say that, but we have to be our own lobbyists. The second is just inuring people to the talking points and the arguments that they're going to see pushed on their TV screens in 30-second increments. And, becoming an organizer, deciding that you're going to spend some time to engage the people around you, to try and move public opinion, that's powerful. That's how we win this fight. And so, yes, vote, but then also ask yourself, all right, how do I become an organizer? And you can, be an organizer with a capital O and go and, work with PNHP and work with the Nurses Union and work with all these great organizations doing great work. And there are many of them, whether it's them, Public Citizen, Social Security Works, great organizations. Or it's just deciding that you're going to be like an organizer with a lowercase o, right? And what does that mean? That means just having conversations with the people with whom you come in contact with about what it is that you believe and why it is our system works. And that means also thinking critically about who you're organizing with. I mean, preaching to the choir is good, it's useful, but it also means going out and preaching to the non-choir. And I always tell folks, if you could choose between one person talking to 1,000 people or 1,000 people each talking to one person, I would take 1,000 people each talking to one person, right? But having those conversations, engaging with folks and saying, look, here's why they want to tell you that it's going to cost too much. Here's why they want to tell you that it's going to take away your choice. Here's why they want to tell you that it's going to cost jobs. It's because it's going to cost them money. And that money that you pay every month, every 2 weeks, that your employer pays, it could be money in your back pocket to get access to healthcare that was always there for you no matter what happened, right? That's what this is about in the end. This is what it comes down to. And so ask yourself, who's making money off of this and who loses? And in the end, you'll find that the industry makes a lot of money off of this and you lose. And so that's the real problem. And I think that there is a lot of opportunity that we have to becoming, right, organizers on this issue, building the kind of national momentum, continuing to hold our elected officials accountable, being the counter lobbyists to industry that really does make change in the end. Don't forget, Medicare, right? It was attempted until it finally passed. You just got to pass it once. And in the end, history shows us that once you give the American people access to something, they usually like it and they're going to protect it at all costs. We just have to get it passed once. And that's got to be the work. And so we've got to decide that we are going to be a part of this slow and steady movement, building to oppose their money, their fear mongering, and their profiteering off of our bodies.
And in the beginning, Abdul, you warned us to not stay abstract, but actually listen to stories. And I want to read out two other questions that have come in because they share stories, personal stories. One person wrote, do you think employers also contribute to this problem? My father is in his mid-50s and hasn't been able to find a benefited job, although he's offered plenty of positions as an unbenefited consultant, but that means he has to pay out of pocket about $800 a month for his healthcare. And that's actually one of the cheapest options available to him, which means most physicians don't accept his insurance, so he simply goes without care. I mean, I am sure you have heard many, many stories like this, but let's answer the question about whether employers are also contributing, but also I wanted to just read it in full.
So, it is an interesting moment. First, I want to say I'm really sorry to hear that. That's really awful, and nobody should go without care. Particularly at that point in your life, right, where you're sort of caught between two systems. The reality is that employers, on the one hand, know they're getting fleeced by the system, and on the other, they want to control the money that they pay in. When I ran on a single payer program here in Michigan, we calculated that corporations would actually save money, right, on the system. They'd be paying more in taxes, but they'd be saving a lot in those costs. But for large employers, they've been able to take advantage of a catch-22. On the one hand, they can compete over offering bigger and more luxurious benefits packages, right? And so they don't want a baseline package for everyone. And on the other, they know that the nature of our economy now is that people will take these gigs over long-standing benefited work, and so they can offer that as a product for an incentive for one piece of the employment pool, and for the other, they can get away without offering anything. And particularly for low-income workers, right, who are making, $10, $15, $20 an hour, they're basically being subsidized by Medicaid. And the interesting thing, though, is that this is creating some really strange bedfellows. One of the biggest corporate supporters of Medicare for All is DoorDash. And you can imagine why, right? Because their entire model is that we don't actually have employers. Employees. We just have contractors. And because we don't have employees, we just have contractors. It'd be great if the government footed their healthcare bill, because then the pressure on us to provide our employees benefits would go away. So it's an interesting moment that takes advantage ultimately of our societal inequity. And we have, in effect, a two-tiered system. Folks at the very top of the economy are getting lavish benefits and pay, and folks at the very bottom are getting nothing, and their insecurity is not being handled because we don't want to invest in high quality benefited work, nor do we as a society want to invest in a high quality social trampoline, right? And I don't like the term social safety net. You don't just fall into it, right? The idea is that it bounces you back up. So
Abdul, we have 2 minutes left, and I want to give Mary and you a chance to sum up, but I do actually, out of respect for the person who wrote this question, who has a mother who has a disability, I just want to read to you 2 sentences. She talks about having to deal with sort of changes. We're still going through a horrible appeal process with hundreds of pages of policies and instructions. Is there anything we can do to prevent insurance companies from determining on their own what's medically necessary and prevent them from devastatingly ending previously covered treatments? I'll ask you to type in an answer because I don't think you can answer that, but I just want to say it's real. People, we are only 60 people on this call, and 2 have talked about their personal struggles right now. Mary, I'll give you a chance to answer any, to summarize. We have to pass it back to Veronica, but any thoughts about this conversation?
Well, I really think, Abdul, I want to thank you for talking with us about this, and to point out that one of the key human rights is the right to health. So this is a very appropriate topic for us to be discussing. And the right to health part of it is the right to health care. And I think many of us in public health have been negligent in not holding up healthcare as a key part of the continuum of a healthy life, as well as its role in our society as providing jobs and so on. So I want to thank you for a really sweeping and a sweeping summary and a very fine book.
Abdul, any closing remarks?
Just want to say thank you for hosting me. It was an excellent conversation. Really appreciate you, Mary, and you, Natalia, for the work that you all do at FXB every day. And the advocacy for a more just, more equitable America and world. And we have to see this in the broader fight for human rights in this country. And we don't often think about it as human rights. We talk about civil rights instead of human rights in America, but this is both a civil right and a human right. And I think we have to frame it that way. So thank you for the work that you all do. Thank you for including me and inviting me to share today. And really appreciate everybody who joined and engaged in the conversation, becoming that little O or big O organizer for a more human rights oriented healthcare system in our country.
Well, thank you to both. And Veronica wanted me to just convey that this will be recorded and on our website at fxb.harvard.edu and shared more broadly. Thank you, Abdul. Thank you, Mary. And thank you, Veronica, for all your work to organize. Have a good day.